So welcome to the latest episode of A Dose of Digital Health, and I'm extremely chuffed to be back at the Bharani Medical Centre with Bharan. So Bharan, it's great to see you again. It's been about 3 or 4 months, I think.
It has great to be here again.
How are you?
Good. It's an exciting, as always, it's an exciting time to be in primary care.
Good. We left last episode, on a bit of a cliffhanger. You mentioned Robocop, which is incredibly interesting. So we wanted to come back and explore some more ideas, and you seemed so enthusiastic with digital health and the changes that are happening right now, and the efficiencies that are being worked on. So we just want to come and see you again and really explore Robocop. So tell me.
So I get inspired by lots of different things, but the whole Robocop concept is something which loved the film and thought about, how Robocop applies to kind of the NHS. So if you forget Robocop for a second, if you remember watching EastEnders back in the late 80s. Back in the day. So I grew up in EastEnders. I think my mum put me in front of EastEnders when I was 1 year old. I used to recognise the theme tune. But do you remember in EastEnders there used to be the GP, Dr. Leg?
Everyone remembers Dr. Leg.
Old school, right?
Yeah.
What was Dr. Leg? Dr. Leg had the coat, he had the hat, he had the bag. And they used to say things like, "Oh, let's send for the doctor," and Dr. Leg would come running along. He knew everyone, didn't he? He knew everyone. He knew everyone's friends, he knew family, everyone in the pub. He knew grandchildren. So there was that massive sense of ease, right? Dr. Leg was probably a super efficient resource in the NHS, right? He was a super efficient clinician because actually, whatever he was getting paid, he would do things really, really quickly, and he knew everyone. So he was able to make decisions really, really quickly. And he had that continuity of care, which is super important and which we're lacking in the NHS, right? Now, how do you get the Dr. Leg of today? What was Dr. Leg's big component, right? It was continuity of care. That was the essence of Dr. Leg. Now go to the film Robocop, right? What was Robocop? Robocop was an excellent police officer. Murphy, I think his name was Murphy.
We're talking the original Robocop. The original
Robocop. Oh yeah, not the reboot. We don't do reboots. We do originals only, 80s and before. I think it was Alex Murphy, but Officer Murphy was an amazing police officer, right? Like going about doing his day, and what happens? He gets killed. And what did they do? They took the best parts of his human element. That's your continuity of care. And what did they do? They gave him the technology to fight crime at scale. That's really, really important. And they made him really efficient at doing it.
I see where you're going with this now.
Right. And that's the model, isn't it? Yeah. So really, if you can get continuity of care, right? And that is just generally GPs being able to absorb and take on work and really get to know their patients. And we get the magic of that because through the years of general practice through the NHS, with perhaps lack of resources, people being quite busy, it's hard to get continuity of care, and people aiming for that work-life balance because doctors are getting burnt out, continuity of care lost. So we can bring that continuity of care back, and we give GPs, clinicians, the ability to do this at scale. And that's where your PHM models are really important, your population health models, your population health software. So we're able to identify which patients need us most. And the more up-to-date data you have, and the way you're able to get that data instantly with your PHM models, that's what makes you, super specialist or super efficient. And thirdly, the efficiency gains, and that's through technology itself. And we can separate them. So when we use population health models, I'm thinking of connected care, where you're able to see in an instant which type of or which patients may be at risk of cost of living and cost of fuel crisis by looking at how many of them are living in areas of deprivation with poorly heated homes, and then you put in another checklist to see which of those have chronic diseases, right? So you know already that these people might be more vulnerable or at risk, and then you use technology to get to them. And how do you do that? So things like AccuRx, where you're texting patients, for example, or Simul, where you're texting patients, or you're using an OC provider like Anima or eConsult, where they're able to contact you, and the phone line is not the barrier to access. Maybe they can do it on their phones. I mean, I was in the Isle of Wight, and there was a company just driving with the children, and I was thinking, how do GPs operate in the Isle of Wight? And so I actually Googled a practice, and it said, contact your practice via WhatsApp. And it turns out there's some really smart boys who basically have used WhatsApp, converted surgery phone lines into WhatsApp routes, so you can just WhatsApp your practice, and in the back end of that, there's some technology allowing you to contact your practice through WhatsApp. So do you see what I mean? The GP hasn't changed at the end of it. He's still your GP. He still knows you. He still wants to know your family. He's still the family GP, but with models that can help you access him better, and also with tools that allow him to work out which of his patients need him at that time, he's become like he can become the modern day Robocop or Robodoc, or what you want to call it.
Yeah.
And that's the future. And everything I tend to look at or do is really to fit that, to think about that. And when we think about sustainability of primary care, that's the model we have to think about. We have to think about those three components and where it fits into it.
I get it. I would say, I'm thinking about Murphy, thinking about him, how he had to change. What does that mean for you and your colleagues? What does that? So if that's what a GP needs to look like, and a Robo GP, how does a GP prepare for that type of, like, maybe they're not all fit or want to be that type of GP? Do they have to be? Is that to be successful? Do they have to become that type of GP, or are you saying there are versions of that?
Yeah, you can do it to different degrees. You go back to the film, the people who did it badly and didn't focus on continuity of care, they created that Robocop that just killed everyone, right? So if you do it and you get the ratios incorrect, of course you're going to do more harm than good. It really goes back to reflecting on, well, actually, where do you see your practice or your population heading in the next 5 or 10 years, and starting to look at some of your challenges. I mean, that's how I went about it. You know, I came into this game at a young age, with ambitions to do things, but also knowing that, you know, I would need to sustain this for many, many years. Yeah. So I worked backwards as to how could we do things differently. My mum is a practice manager. My father is a senior clinician. I've seen them spend days and nights in the surgery, 10, 11 o'clock. Even now, I don't think people realise like that's what they do. You know, they might leave at 10, 11 o'clock looking at different aspects, because ultimately we are in some ways small business owners, so there's lots of back-end stuff that we have to do, whether it's quaff, whether it's accounting, that all needs to be done. And I look at a lot of that and I think, well, how can I do this more efficiently? Which is the biggest problem, and how do we tackle it in a more efficient way? And it just started with, sometimes those challenges are brought to you. So when I had my CQC visit that went awfully, it was because my long-term disease management in one of my surgeries was poor. I accepted that, you know, we may have tried things, but were they successful? So in the back of my head, I was always thinking, well, that's a challenge. It led to some digital innovation around how we manage hypertension. It led to this expansion in my head and as a practice around looking at quaff differently and digitally. And now I don't even think about it. It's, oh, okay, we're doing that now. And, you know, I can walk in and think, oh, that's what the data looks like. I don't need to intervene as much, you know, and maybe tackle another area. So it's not something that happens overnight, but it is reflection and thinking about your challenges.
It's interesting again, and I think you mentioned that a lot of people don't realise, and this is true, that these are small businesses, and the 10, 11 midnight are real, they're reality, aren't they?
Yeah.
And I wonder what happens if you came into work tomorrow and all those digital and technological elements that you rely on now were switched off. They weren't available. Because you're able to be almost, I guess now you're a kind of a Robo GP in a sense, because you couldn't manage, I'm assuming you wouldn't be able to manage the workload that you have now without these tools. So if you came tomorrow and they were switched off, what would your day look like?
In some ways, it'd be super simple. it'd be like, actually, we'll just go back to old school. Look, old school is always, in some ways, best, right? Patient in front of me, no phone, no technology, basic training, pen, paper, fine. If we disregard the fact I'm a GP and may not be able to read my own handwriting, the patient's probably really satisfied with that. And you know, it's easy, in some ways really straightforward, isn't it? That's what I do. It's all the other bits that you're absolutely right. So actually, quaff will look differently. Maybe some of the CQC requirements, the monitoring, the safety would be compromised because the technology supports it. It's not that it wouldn't happen; it just takes longer to do because you're doing things in a manual way. So it would look very different.
Yeah, and you could cope a day or two, but if that was it's going to be off for a month or 2 months, then you'd have to think about getting more staff in and opening more phone lines, because actually it's about the patients, isn't it? As you said before, when we last met, it's the ability for patients to just book an appointment online or just on their phone. It's that ease of efficiencies and access.
Yeah, absolutely. And in some ways it was like that, pre-COVID a lot. If you go even in the last 4 years, we'd have to revert back to that old model, which would be really a real struggle, actually. And the expectations, we would, if that happened, and you never know, there could be some kind of massive power cut, or all the technology, or the internet gets invaded, whatever, and we would go down that road. I think as a practice, we would do everything we could, but the service would be just poor. It really would be, and it wouldn't fit with the modern NHS.
You'd just be fighting.
Yeah, absolutely. Every day. Yeah, absolutely. Yeah, it'd be really difficult.
Right, Bharan, I want to do a bit of a shift now and talk about social care.
Okay.
Because obviously the formation of the ICS and ICBs is more of a landscape view of the health and social care of an area, and Frimley obviously is not unique in that. But how do you, as a clinician, how do you work with social care now? What was it like before the ICS ICBs were formed, and how do you see that in the future, if that makes sense?
Yeah, so I've got a lot of experience with nursing homes. So as a practice, we look after 3 nursing homes. So that's quite a lot. As an individual, I was leading for care homes in Slough Place. I was the care home lead for Slough. So over the last 5 or 10 years, I've been working with the nursing homes and just kind of developing some experience with it. And how we work with them has changed. Firstly, I think it's become more formalised. So through the ICB structure, through the PCN contracts, every nursing home is aligned to a PCN, because in the past it wasn't always the case. Okay. So actually, because we've got that alignment, because there's specific funding routes coming in, there is an element of standardisation that a nursing home gets a ward round from a clinician once a week, whether it's virtual or phone call or face-to-face. Whereas I think before there was just different practices and different nursing homes were doing things differently, and there was even some private arrangements, so there wasn't consistency in the country. So I think we've moved on from that, and I think we're in a better place. If we look pragmatically how we move on from them, we start to look at some of the challenges. So just as a ground floor GP, going to a nursing home was always not very efficient.
Yeah, okay.
Nursing homes have to keep records in their own way. They have to keep records for their residents. That's I think their rules. I think they're asked by the local authority, by CQC, to do so. So we often didn't have access to that record at all. Now, as a GP who has to see a patient, you have to see a patient. This was the bit I found incredibly annoying. You would have to write in the patient's record in the nursing home for their copy, and then you'd have to go and type it up in EMIS. Okay. When you go back to the surgery, and then you'd have to try and make sure they all correlate. That I found was the headache. The medicine isn't actually that bad. You've got a patient in front of you, you deal with the patient, but it's all this bit which was a headache. It's changed. So firstly, with remote working and laptops, that's obviously gotten better. What I've seen is some nursing homes are investing in technology to help aid that. So the nursing homes we look after, they are invested in a company called Predicare, and it's a game changer, because all the care plans for the patients are online in a secure network. What happened every day, because with the turnaround of staff in a nursing home, you pitch up to a nursing home and there's a problem with the patient, but the collateral history may be tricky to find, because there might be, that person might have been on a night shift and now it's a new member of staff who's just come on and they're going up to date, and sometimes you're looking at paper records. But if it's in one place, online or in computer records, it's much easier to access that. And we can do that remotely now. You can
dial into that.
We can dial into that, right? So we can log in as a GP and have a look, because then we can add our records, our notes into that record. So there's one place for everyone. So if a social worker comes into the home and says, look, I want to see the complete record, then actually it's all in one place. Yeah. What makes it easier is, if you're inputting something onto one system, it's quite easy to copy and paste that into your own EMIS system. So it's made my life a lot easier when I'm looking at patients, and then there's standardization. And these things feel like they're really small in the private sector, in the financial sector, in other industries. This use of technology is just a given, but in the NHS it isn't.
Yeah.
And there's right, one NHS is a slow moving machine, but also you look at data protection, everything, the everything has to be secure, which is fine. So it's taken a little bit longer for these systems to come to place, but when they're there, it means that your time is so much better used, and that's super important, because when you go, 2 hours work can be condensed to 1 hour, so you can do more, you can do different things.
Yeah, it's about those efficiencies again.
Efficiency gains, and that's a big thing with health and social care. How can you, and if you look at the barriers to health and social care, it fundamentally is about information sharing, and similarly with GraphNet and connected care, because of the shared care record, we can see what our community providers can see. So now we're in meetings where I can see access to RIO. RIO is quite a standard operating system which lots of community providers and health and social care use across the country. If I can see that in my EMIS system, and we're having a conversation as a multidisciplinary team, and we all have access to that information, we can actually make better decisions for the patients. So that's what I've seen, is the gap between health and social care is narrowing because of the information that we're all able to see together.
And that's so important, isn't it, in terms of patient safety?
Massively important. Patient safety, efficiency, it's super, super important.
Yeah, that's good. And you talk about data. Talk to me about Microsoft and how that is potentially changing things for you as an individual user, but also the potential you might see throughout the NHS.
So if we park ChatGPT aside for a second, because automatically we think of that, even their most basic apps are changing the way we work. So N365 is the suite, the Office suite, where we have access to OneNote, OneDrive, Microsoft to-do lists, sticky notes. There is so much within the N365 that we can use. When we come out of this, when we sit in the chair, a lot of our time is focused on managing the patient, right? So looking at what the patient's come in with, their medical problem, how we treat that, how we follow them up, and use of the actual EMIS clinical system or the Vision clinical system or TPP, whichever you're using. That's a big part of your world. But no one sits down and teaches you, well, how do you manage your day? There isn't any formal training around MS Teams, around using the calendar in Teams. There isn't. And perhaps clinicians who are not used to technology have struggled with it.
Is there just an assumption then that clinicians they're growing up with it now, so they should just know how to use it? Do you think
there is an assumption of what you do, and that's a bit of a shame for clinicians who have spent 20 years in general practice and suddenly it's on them. And I've had conversations with clinicians trying to access a Teams meeting and the struggle with that. So it's not easy. But we are really fortunate. We're in a position where we have the N365 suite, where we can actually then start to use it to incorporate things in our day. So we can use our Microsoft sticky notes to take notes as we're going through our day, knowing that will be transferred from my laptop, my work laptop, obviously to my work computer. Before we were carrying around lists of paper with us all day with stuff that we have to do. The need for that is pretty much gone. OneNote is fantastic. You can put all of the things that you have to deal with in your OneNote, and it will be stored securely in there. Again, it sounds so simple, doesn't it? It sounds simple when I even think about it, that why haven't we been doing this for years? But if you're a GP and you're managing general practice and then you're going into your other roles, or even if you're just doing general practice sessions, this stuff is so important, because organisation is the key to our game. And I've seen lots of clinicians get stressed and anxious and burnt out. And when you ask them, why are you stressed and burnt out? Because ultimately, you haven't killed any patients. You've done a really good job as a GP. And often it's just due to volume of workload, volume of admin tasks. That's what stresses people. And actually, by embracing these tools, getting people to use them, getting people to function with them, they'll feel that actually you don't have to remember everything. You don't have to get overwhelmed with a stack of papers, or that you're going to miss a referral, or you're going to miss doing something you're supposed to, because you have all this technology to support you. What I think is we should be investing more in training people in how to use them, but how to use them in their days.
That would make sense, wouldn't it? Because we as a commercial organisation have these tools, the same tools, but obviously the service we provide needs to meet certain criteria and what have you, but we just use them every day.
Yeah.
But actually, I mean, we're trained, but there's also still the assumption that we would just get on and understand how to use them. AI, for example, you mentioned ChatGPT. It can be really helpful in your day just by running off a letter. You haven't got to think about it. You can give could you write me a letter that contains these elements here? You check it and it seems to read really well, and off it goes. It helps you do more.
Exactly.
But I think, as you mentioned there, if you haven't had training in it as a GP clinician, there's the assumption you just understand it, then you'll just become more frustrated. You will with the whole. It's just more digital, more tech. Actually, it's not for me. I just want to do it this way.
Yeah.
But if you spend time, and it could actually be a few days, not the odd hour here and there, but maybe like a 1 or 2 day course that they have that goes through the different sorts of tech and the options that there are. You haven't got to use necessarily this one. This one does a similar thing, and do it at the beginning of the day. We advise you to do it at the beginning of the day, and then throughout the day, and at the end of the day, you look at your list and whatever. But there's almost so much noise now from apps and different technologies, isn't there? You've got to kind of say, I'm going to use these ones here and see how I get on with those. And then you'll learn from your other colleagues and other people and social media, whoever, about other elements that are coming on, other solutions. And then you'll hopefully just be then introduced to it and it'll just be part of your life. I mean, I and my colleagues, we couldn't easily get on that without just tech such as all the Microsoft apps and obviously Teams, and using Teams better, and Teams is becoming better as well. And so Outlook is becoming better, and I just think we couldn't do it. We couldn't do without it. And I would imagine a GP and any other clinician is going to struggle unless they understand how these things work well and when to use them and not when to use them.
When to use them. And then I think the danger we're making in the NHS is we're throwing technology at people. We're not explaining to them why. We're not addressing the challenges in that conversation. So then the person who's not technology minded is sitting there thinking, what, another piece of technology? Why are you throwing this stuff at me? But explaining to them in that way that, look, if you have a problem, there's a technological solution to this that can help you. And it's constantly changing. I think, and then, when we're talking about lists of patients, I remember having to go on YouTube and I was trying to figure out how you can get 2 lists, compare them, and filter out the duplicates.
Yeah.
And there's a formula. I was trying to, on YouTube, someone was teaching me the formula. I found it so confusing that I think I just gave up. I thought, forget it, because it just didn't work.
Was that the Excel VLOOKUp thing?
It was VLOOKUp. Yeah, VLOOKUp. Yeah. How many people have tried VLOOKUp?
Oh, yeah. And then you find a guru in VLOOKUp, then they're the person that you need to go to.
Yeah. I mean, my sister-in-law got a first in maths from Imperial. She was like, VLOOKUp is awesome. I was like, yeah, but it's not. It's really it's not
for the average person.
It's not for the average person. I'll say that. Not for me at all. But now Excel has changed that, so they've got actually a little box which you can click, and it will it's almost incorporated VLOOKUp in a user-friendly way. So stuff is changing all the time, but you wouldn't know what to look for until you knew, like, that's the problem. Yeah. That's the tech I need. I want something different that's going to help me manage this differently. And I think because we're in this realm where people are overwhelmed, there's different things coming at them every day. Sometimes people aren't in a place where they just need to look up and say, actually, what is the problem here? Whether it's being able to do cough earlier, or maybe just maybe members of staff are leaving and you've trained them, and how do you bring in that same level of efficiency, but you can't employ another member of staff, it's going to take too long to train them. What were they doing? Could it be replaced by technology? Is there a technological solution? A lot of people aren't in that headspace to do it. Yeah.
Well, talk about VLOOKUPs and lists and quaff. Talk to me about AbTrace.
AbTrace is good. AbTrace is really interesting. So I think we're the first in Frimley to have actually bought AbTrace. It's a really nice piece of software. It sits alongside with your EMIS and it pulls data from EMIS, and it's updated daily. One of the problems that we have, we're a large, in Slough alone, I think we're about 17,500 patients. We have patients on multiple disease registers. For example, someone might be diabetic, they might be on a complex medicine. Those 2 lists, so that now they're already on 2 lists. Mm. Maybe they've got COPD, they'll be on 3 lists. For each list, they'll need separate things done throughout the year or within different teams. Exactly. So they might need a diabetic review yearly. If they're more complicated, they might need that every 3 months. They might need a COPD review every a year. But within the COPD and diabetes, there's things that they need done. if they want a complex drug like methotrexate, they might need bloods every 3 months. So now you've got someone on 3 different lists who need lots of different things, plus their day-to-day problems as well. How do you get them in? How do you contact them? So now I can have one member of staff looking at 3 lists and contacting that patient 3 times. She could do that. Or I can use VLOOKUP. All right. Use VLOOKUP. Good luck with that, right? And good luck updating VLOOKUP, because that's a headache in itself, right? But what Abtrace does, it kills that. So basically, with one patient, it will find everything that patient needs in a very user-friendly way. So actually, if we're just calling them in for a blood test, the person who's the phlebotomist at point of access, so in the consultation, can look at Abtrace and it will tell her exactly what that patient needs, and it will tell her these are the exact blood tests that this patient needs at this time. If she can happen to do blood pressure, for example, and the patient needs it, it will indicate. It will tell her what the patient needs within the QOF year, what the patient needs in a calendar year as well. What's really cool about it is that actually it will start contacting patients itself. It's got rule sets. So 7 days before patients due maybe thyroid bloods because they're deficient in thyroid and they're taking thyroxine, it will contact them and say you'll do a blood test. Contact your practice, or you can even self-book using the link below. So it's automated now, and that's something we've never had in general practice. We could text people, but there would be someone at the back end of that text, putting off a list, maybe using VLOOKUP, a CSV file, plugging it into something like Accurex to send that group of patients a message. Now that happens automatically. So that's a massive game changer. For us, actually. That's a really big thing.
So that helps the Robocop.
It does help the Robocop, yeah, absolutely. And it allows me, even from a monitoring point of view, because the thing with Robocop is, what I want to be able to do is in a snapshot. If you said to me, look, how many patients on your diabetic register and how many patients have outstanding bloods, I want to look in, I want to be able to time that in within 5 seconds. As long as I'm on a computer within 5 seconds, I want to be able to look that up, and I can. Yeah. I want to be able to do it. If you said how many diabetics and COPDs are outstanding, within 5 seconds, I want to be able to do it super quickly. Now, if you said something more, that might be easier, that might be easy now. But if you start to be obscure with it and say, well, of those, how many specific need blood tests, and how many of those are also got patients who how many of those have are on complex medicines or DMARDs, I can do that with Abtrace in a snapshot. But more importantly, I can train someone else to do that very quickly, and that's also will save me time. It will make things more efficient and make things better for the patient. If we put the patient at the centre of this, the patient's contacted, and whoever's contacting them will look at Abtrace and say, actually, we're not going to book you with a phlebotomist because they might just be able to do your blood test, because I think you need a blood pressure check and a foot check, so therefore we'll book you with a nurse. Even if I've got nothing, even if I'm not contacting them about diabetes and I'm contacting them with a blood test, I'll be able to see they do this and this also, which is really, really helpful. So
you get a holistic view of the patient rather than seeing them for a specific LTC.
Yeah,
you're seeing them for the whole kind of the whole profile of that patient.
Absolutely, at point of booking.
Yeah,
which is really important, because there's going to be people who watch this and say, actually, you can do it with the technology we have now. So I can. Senior clinicians could do it. People who are good with the technology can do it. But when you're getting a movement within the practice, not every member of your practice can do that. And Abtrace allows everyone to do it.
Yeah. That's incredible.
It is. It really is the future. And it's things like this which give me a lot of excitement, because 5 years ago this stuff wasn't around. We were running lists, we were giving lists to people, paper copies floating about, and it just wasn't there. And now we don't need any of that. So there's hope that actually things will get a lot better in the next few years.
So I think that's a good place to finish, actually, because it'd be really nice to come back and see you again in a year and see how things have changed. Yeah. If they've moved on a little bit. I suppose, because I don't think they have to move on too much, actually, from where you are, because you almost seem to be converted into this Robo GP. But it'd be very interesting to see how maybe Frimley have matured in terms of their connected health and the connected care record and things like that. And it'd just be great to meet you again and see where we are.
Yeah, absolutely. Looking forward to it.
Okay, Bharan, really nice to see you.
Nice to see you.
Take care.